Hey nurses, thanks for watching. Today we're going to go through how to do a Braden scale, determining an appropriate level of pressure injury risk to develop a care plan and interventions is super important to our population because pretty much everyone who comes in to a skilled nursing facility, whether it be for rehab care or long-term care, pretty much everybody's at risk, and so we need to determine what level of risk they're at so that we can appropriately intervene and prevent pressure injuries. So this education, it'll go fairly quickly. This is step one. And some other things I'm going to be sending out in preparation for some skills checkoffs that we're going to be doing in September. So in general, pretty much anyone who admits to the Morrow home is considered at risk for pressure injuries, whether that's due to age, comorbidities, mobility problems, surgeries, nutrition. Pretty much no one who admits here is going to be not at risk for pressure injuries, or they wouldn't need to be here. So if you're frequently performing Braden assessments with a determination that the person's not at risk for pressure injuries, especially if they have a history of pressure injuries, I've seen that before, you're probably not doing the Braden correctly. So that's why we're going to go through and develop our skills here, our assessment skills, so that we can determine an appropriate level of risk. Now, the Braden is not all-inclusive. There are over 100 risk factors for pressure injury development, and the Braden covers 6 sections. So it's not, like I said, it's not all-inclusive, but it is a good first look at determining what kind of risk someone has. So a Braden scale focused assessment is a focused assessment. It's the same kind of assessment as like listening to lung sounds and determining whether the lungs are clear or not clear, and listening to vowel sounds and determining whether vowel sounds are active or not active. So it's essentially fine for basically any nurse who has been trained to complete this assessment. So LPNs and RNs, nurse techs, even if they have gone through the training and they are competent to perform the assessment, they can also do this. So for most individuals, our standard interventions are appropriate to prevent pressure injuries. And those standard interventions are the Reassure pressure redistribution mattress, an Equigel general cushion, a heel lift cushion, regular incontinence care, promoting fluids, nutrition, reposition for preference, and therapy screens. I do see a lot of times, and we've talked about this in other in-services that we've done, where repositioning is like a by the book every 2 hours. That's just how we do it, and that is not the standard of care anymore. So I need to get us to stop thinking that repositioning needs to be done based on patient preference and need. So if someone needs to be repositioned hourly, or if someone needs to be repositioned every 4 hours, based on their risk and their own mobility, like that's something that we need to be addressing. We do not have a standard every 2 hour repositioning anymore, so let's stop thinking that way. Anyway, side note. So for high risk individuals, when we determine a Braden scale of 12 or less, or a Braden scale of 13 to 14 with additional comorbidities, we need to implement other interventions to prevent pressure injury development. So we put on an air mattress, an Equigel Performance or a Roho cushion, and the Equigel Performance cushions are the bigger green fat ones. They basically have this same pressure redistribution capabilities as a Roho, but actually are almost better because Roho does nothing to prevent or eliminate moisture to the skin, which is a whole nother risk factor. So an Equigel Performance is actually really good. It's a very good cushion. Heel lift cushions or heel boots, registered dietitian referral, hourly repo, etc. And we may need to advance some of those interventions if the ones that we've put on aren't effective. So we might need like alternating air devices, like an alternating air cushion. We've got a couple residents with those. Or to add additional therapy services, speech therapy even, to deal with like a nutritional problem. So it's important to determine an accurate level of risk. So the Braden scale focused assessment uses 6 categories to determine risk, and we're going to go through each one of these. So we're going to look at sensory perception, moisture, activity level, mobility, nutrition, and then friction and shear. And we'll go through how to code each of these, and then we're going to go and actually go into ECS and perform a Braden assessment on one of our residents. So sensory perception is the ability of the resident to feel discomfort and to react to it. So pretty much everyone's got some level of risk if they use opiates, if they have other medications that impact the neurological system, if they're diabetic. So actually, something that we're adding to this assessment, if a resident has diabetes, they need an additional assessment called a monofilament test to determine sensation accurately. So we have to do these foot tests, and I will click on this link so that you guys can see how to perform a monofilament test. Any nurse can conduct this test. So basically, if a person has a completely limited sensory perception, it means that they either can't really feel anything, or they cannot react to that at all. So we have some people who have really significant dementia, who can't communicate their needs, who can't verbalize discomfort, who can't respond if something on their body, like if they've been sitting too long and it's uncomfortable for them, but they can't do anything about it. That would be a completely limited or a very limited result, depending on the individual and how mobile that person is. Now, a slightly limited, they might have some trouble communicating their needs. Maybe they failed their monofilament test, but pretty much everybody is going to have a slightly limited, or at least a slightly limited sensory perception score if they're residing here. Very rarely are you going to get a no impairment. Basically, people who admit here, they have some degree of impairment in their sensory perception. Now, it's not impossible to get a no impairment score, it's just not very likely. So let me click on here, and we are going to watch how to do the monofilament test. I think.
This is Dr. Lanzaris from 360woundcare.com, and today I'm going to be demonstrating the Sims-Weinstein monofilament testing for loss of protective sensation in the diabetic foot. The monofilament test is performed with a standardized monofilament. The ideal is to use a disposable monofilament, as a reusable monofilament can expose the patient to infection, and over time the filament will wear out, leading to less reproducible results. As you see on the model here, there are 10 positions that are demonstrated for ideal testing for the monofilament test. There's 9 on the plantar surface of the foot, and there's 1 on the dorsal surface of the foot at the web space between the first and second toes. The test is very easy to perform, relatively inexpensive. Some of the things you want to watch out for when you're performing the test is to avoid areas that are obviously ulcerated or have heavy accumulation of callus. Try to find alternative sites if possible. A positive test is signified by greater than 4 out of the 10 points being insensate. The test is simply performed by taking the monofilament and pressing it against the skin until it just begins to bend. Ideally, you'll want the patient to demonstrate a yes or a no if they feel the sensation. Some tips and tricks is to vary the rhythm at which you perform the test, as some patients will get familiar with the rhythm. So you want to vary how often you're pressing, and you also want to alternate sites, not using consecutive sites. This adds a little bit of randomness to the test and helps the test to be a little bit more accurate. It's very important to apply even and equal pressure to the monofilament when it's in contact with the foot. Ideally, you want to just push until you see the monofilament bending. That's all the pressure that you need.
So moisture is another one of the 6 sections, and you have another range of 4 different categories where you can code somebody. So I see this miscoded quite often too, and I'm not really entirely sure why that is. Basically, what we want to do is determine the level or the degree of moisture that someone's skin is exposed to, because we know that people who are incontinent have a much higher risk of skin breakdown than people who are not. So you can have a constantly moist environment, and this is for any location on the body too, so just keep that in mind. If someone has severely, like, heavily exudating wounds, if they're always perspiring, and a lot of times you see that in terminal care, then their skin, you're going to code that as constantly moist. Very moist would be like a resident who is incontinent 2 or 3 times per day and required frequent brief changes. Occasionally moist would be like the resident's generally continent or incontinent 1 time daily or less. Maybe they have an indwelling catheter and they have like just some minimal, very minimal bowel incontinence or something like that. Then you get like an occasionally moist. And rarely would be that the resident was continent, no wounds with drainage, very little perspiration, that their skin is not ever hardly exposed to moisture. Activity, again, 4 sections to code, or 4 choices for how to code. So you can have a resident who's bedfast, who's confined to a bed all of the time, all or most of the time. A bedfast patient may be a Medilift transfer. A Broda chair is still considered bedfast. So if a resident is Medilifted from bed and when they get up, they're primarily in a Broda chair, that is a bedfast patient. Chair fast would be a wheelchair or recliner all the time. The ability to walk is very limited or potentially non-existent. Walks occasionally would be like a person could walk short distances. So let's say a resident can't walk in the hallways, but walks to and from the bathroom with the CNAs like 15 feet 4 or 5 times a day. That would be walks occasionally. And then walks frequently would be somebody who walks up and down the hallways at least twice a day, who walks around in their room, maybe with help, maybe without, that part doesn't matter. And the assistive devices don't matter, but basically when we're coding walks frequently, this is a person that we're seeing walk up and down the hallways at least twice a day and ambulating in their room. So, mobility. Again, we're talking kind of more about the degree of like bed mobility, transfer status, all that stuff. So a resident who is completely immobile can't initiate any movements independently. They have severe dementia that limits their ability to move. Maybe they're comatose or in some sort of vegetative state, but they cannot or do not initiate movements independently. They'd be completely immobile. A very limited coding would mean that the resident can move their extremities, but maybe doesn't have a lot of meaningful or purposeful movement. And the movements that they can do don't help redistribute very much pressure. So if a resident can't shift in their chair, like side to side, or really do anything that would alleviate pressure on a certain part of their body, if they can't lift their leg up independently by themselves to get that heel off the bed, if they can't switch from side to side in their wheelchair, that would be a very limited mobility rating. Slightly limited would be residents who can make changes to their body position, but they still require assistance with ADLs and transfers. So if a resident can like stand up on their own or shift from side to side, but they still need like assistive 1 weight bearing for bed mobility, or assistive 1 with transfers, or assistive 1 with ambulation, stuff like that, you're going to see a slightly limited rating. And then no limitation is that the resident completes all movements, ambulation, transfers, repositioning, ADLs independently, and does not need nursing assistance. So they probably shouldn't be in a nursing home. So you're really not ever, until like the point that someone's ready to discharge and go home, going to get a no limitations mobility score. Nutrition, again, 4 categories. Very poor is going to be almost never eats a complete meal, maybe eats 25%, and does not really drink their supplements. Probably inadequate is going to be someone who eats maybe half of their meals. Maybe they refuse breakfast every day, consume at least 3 servings of proteins and dairy per day, kind of eat a varied diet. Adequate is going to be someone who eats more than half of their meals, might take supplements, eats at least 4 proteins a day, or someone who has a tube feeding that's managed by the dietitian that would meet the nutritional needs. Even if they don't have PO intake, we would consider that a score of 3. That would be adequate. You're meeting most of the nutritional needs. Excellent would be someone who eats all their meals, never skips a meal. We have some residents like this, so, and they eat snacks all the time. I can think of 2 right off the top of my head. And then friction and shear has 3 different categories, so it's the only one with 3. And so I also wanted to draw everybody's attention really quick to this, the difference between friction and shear, just because I feel like it's a good time to do it. So friction is the rubbing of one body part against another, or one body against another. So you're not just rubbing body parts. You could be rubbing something against the bed, rubbing a foot against a shoe, rubbing calf up against the wheelchair. So it's, and if a skin injury results from that, it's called a traumatic injury. It's a friction injury. It's not a pressure injury. So just keep that in mind. Friction might increase the risk that someone will get a pressure injury, but it is not. Friction injuries in and of themselves are not pressure injuries. So if we are seeing like someone who gets a blister because we're pulling out or sliding out the easy sling, that in and of itself isn't a pressure injury. That is a friction injury. And so it's going to be any friction injury that you see pretty much is going to be pretty shallow, hopefully. Shear, we call things sheared injuries all the time, and I do it too, because in normal, common, everyday language, you like shear the top layer of skin off, or you shear a sheep. Like, I mean, so the word makes sense, but shear is actually an internal thing that's happening to the body that you can't see. Shear is a gravity force pushing down on the patient's body with resistance between the contact surface. So I know I've got a picture in here because it's kind of hard to describe what I'm talking about, but basically, like, it's the movement and breakdown and disruption of internal tissues. You can't see a sheared injury. And I'll pull the picture up. So when you're looking at a determination of friction and shear, you have the 3 categories that you can rate someone at, and the one that I don't see coded very often, but is the most common here, is a problem. If someone needs bed mobility assistance pretty much at all, or has the head of the bed elevated most of the time, there is a problem with friction and shear. It is happening. If we can't see it, if it's not apparent, if they don't have injuries, well, if they don't have injuries, great, but it's still a problem. Because we can't see inside their body, we don't know what's happening, especially with that head of the bed elevated. Those tissues like around the sacrum, the blood flow is going to get disrupted. You're going to have some shearing injury. And again, like I said, shearing is something that you see internally. A potential problem would be someone who really doesn't need very much assistance with bed mobility. They can maintain good trunk control, they don't slide down, they can sit themselves up on the edge of the bed. Then you kind of have a potential problem. So maybe it's not as much of a risk, but it's still, the risk is still there. And then no problem, pretty much not going to happen until someone's ready for discharge. They don't require any assistance with bed mobility. They can reposition themselves without sliding. They can stand up to reposition, all that stuff. So this is the picture that I was talking about. Shear is mechanical stress. So when you have a sheared injury, your skin, you can't see me touching my screen, so stop that. It's the internal tissues, like the back, the skin on this person's back is like stuck to the bed, but the other stuff is sliding down, and it's causing shear inside, disrupting blood flow there on that sacral area. So, just as an FYI. You guys probably aren't going to use this terminology a lot, but I still wanted you to understand what it is. So the presence, like I said a little bit ago, the presence of additional risk factors are going to advance a resident's level of risk. So if you have someone who's at mild risk, but they also have diabetes and they failed their monofilament test, you're going to advance that person to a moderate risk. It really doesn't change much about what we do with interventions. The time when this matters is that when you see someone get a high risk score, or someone get a moderate risk score with additional risk factors. So we just actually had someone I did a Braden on that got a score of 13 and had some additional risk factors like a hemoglobin. I think their hemoglobin was 7.4 or something. It was really low. So a hemoglobin under 12 is an additional risk factor for pressure injury development. A systolic blood pressure that's frequently less than 100 is a risk factor for pressure injury development because of perfusion. So when you see those things, you're going to have to switch the interventions from a moderate or a standard protocol to a high-risk protocol, and that's when we would bring out the air mattress and the special wheelchair cushion, and consider heel boots, and consider an alternating air cushion, and all of that stuff. That's when we do that. So there's a lot of different things that create the need for more interventions. We just need to be aware of what those are. And now we're going to do a Braden. So each resident or each nurse is going to be assigned a resident to complete a Braden on when we do our skills check, and I will post when we're going to do that soon. It's going to be, we're not all going to get together in a group. It's going to be like really cut and dry. You'll stop down, cut and dry. That was the opposite of what I wanted to say. It's going to be like very flexible. You'll just come down when you have time, and we'll go through these things, and it'll probably take about a half an hour, maybe less. So let's put that down, and we're going to, so I do post these videos on YouTube. So the information that we're going to be looking at is on a real resident, but that resident's name has been blocked out. So there's no identifying information here. So we're going to look at a few things, and these are the things that I want you guys to look at and ask about and review the record for when you're completing a Braden assessment. So we want to look at continence and how often the resident is incontinent. So, like I said in that moisture section for coding, we want to look and see were they incontinent 2 or more times per day, less, at all. So here we can kind of see that there's multiple incidents of incontinence happening daily. So probably not always moist or constantly moist, because there are some continent times, but definitely at least very moist. And then let's look at intake. So you kind of want to go back at least a week. I would check weights just to make sure that you're not looking, because if a resident's been losing weight over the course of 3 or 6 months, their nutrition is not adequate. So we don't want to mistakenly code something like that. So if a resident has a weight loss, I would not be coding an adequate level of nutrition. But we're looking here, we want to see if the resident declines meals. There's some 100%, which is awesome, but there is a lot of declines here. And so we're going to say this is probably an inadequate diet or an inadequate nutritional intake. And we're going to look at the care plan. We want to know about how the person moves. So definitely some potential problems with mobility, not able to ambulate if we're using an easy stand for transfers. ADLs are spent weight bearing, so we can see that there's definitely some mobility problems, and that we're probably looking at a chair fast person. And we can see they use a wheelchair, not a Broda chair, so it wouldn't be a bed fast person. It would do this would be a chair fast person. And then you want to look at the diagnoses list and try to make a determination. You're looking here specifically for if the resident has diabetes or impaired sensation, and it does not look like the resident has diabetes. It also doesn't look like they have anything like hypotension, which would be an additional risk factor. They do have hypertension. There are some cardiac illnesses listed here, and so that is going to affect perfusion and create additional risk factors. So then we'll check out our person's care plan, and we can see the incontinence. We can see that we need to or we can see that they need assistance with bed mobility, repositioning, all of that stuff. So I think we have enough to do our risk assessment. So let's perform a Braden. So we're doing a Braden scale. For mobility, it looks like the person was pretty limited. Needed an easy stand for transfers, not ambulatory, so probably not, especially if needs a mechanical lift, probably not able to make any significant changes to the body position. Definitely a problem with friction and shear. The head of the bed on this person's elevated all the time. They need extensive assistance with bed mobility, so we're definitely looking at a problem. We said we were looking at a chair fast person. Moisture, we looked at the level of incontinence, so skin is very moist. Nutrition, it looks like nutrition is not very adequate with all of those skipped meals. So we are going to go ahead and put that it's not adequate. And then sensory perception, our person doesn't have diabetes, so we don't need to do a monofilament test, but it looks like there is somewhat of a limited response to the ability to feel discomfort. Because there's problems with mobility, there's problems with moving, there's going to be problems responding, and there's cognitive loss. So we'll add that up, and our person has a score of 12, which is a high risk for skin breakdown. Now, the last assessment that I looked at for this person was coded as a 15, and there's a big difference in the interventions that get coded as a 15 versus the interventions that get coded as a 12. And here, not only are we at a 12, which is a high risk for skin breakdown, we also have heart disease. So we're at high risk. Alright, so if you guys have any questions about how to code the Braden, if you have any questions on what to do with that, please let me know. I will be happy to walk through stuff with you. It is not necessarily all black and white. There are going to be some variations in how different people code certain categories, and that's okay, but overall what we're really trying to get to, the meat, the root of what we're doing with the Braden, is determining who needs the advanced interventions, because we do not want to grow pressure injuries on our people. So as long as we get that all accomplished and we're able to do this accurately and adequately, I would say that we'll be ahead of where we are right now. So anyway, I hope this is helpful. Like I said, if you have questions, let me know.